Let's transition and talk about reducing cardiovascular risk in the broad population of patients with diabetes. Dr. Bloomgarden, could you talk about the relationship between diabetes and heart failure?
Sure. So diabetes is associated with increased likelihood of atherosclerotic cardiovascular disease, period. We know that. And certainly individuals who have myocardial damage have decreased heart function and are at risk of heart failure. In addition, there are a variety of, we know about insulin resistance and the hypercoagulable state of diabetes, but it's not as widely appreciated that there are many pro-fibrotic factors which are expressed in persons with diabetes. And so the myocardium actually undergoes fibrosis, and this can be found. And then there's a whole entity of microvascular heart disease, which is not quite as well characterized, but certainly has been well shown in animal studies and in man. And so for a variety of reasons, persons with diabetes have evidence of decreased heart function, and endocrinologists are now aware of two different types of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And these are extremely important causes of morbidity and mortality. People with heart failure feel tired. They have less energy, and then eventually they progress to peripheral edema, dyspnea, all the classic things that we learned. So every day I see someone who comes in, who I may have known for many years, and now they're saying, I don't feel so good. And I know this is someone who has had documented coronary disease in the past or whatever. And so it becomes very attractive to say, in this population, which is so common, we may have a specific drug that could be useful.
Mm-hmm. So Dr. Inzucchi, what have we learned since the initial findings about the effect of empagliflozin and the rates of hospitalization for patients with heart failure?
So this was a secondary endpoint in EMPA-REG, and the effect was quite strong. It was about a 35% risk reduction in a very common scenario, which is a patient with type 2 diabetes with known coronary artery disease who gets admitted with edema, pulmonary edema, other signs of either heart failure with preserved or reduced ejection fraction. A real epidemic, I think. Our cardiology colleagues are getting so good at saving people during their acute coronary syndromes that many patients are now living with somewhat damaged ventricles. So the 35% risk reduction, we saw that, and we wondered whether this was something that occurred in patients with established heart failure, or was it preventing heart failure episodes? And I think the answer is both. Unfortunately, we did not have good baseline left ventricular studies in our patients, so we can't tell you who in the study had so-called HFpEF, with preserved ejection fraction, or HFrEF with reduced ejection fraction. But what we do know is that of the 10% of patients who did have heart failure at baseline, at least by history, they experienced a reduction in their heart failure hospitalization rates that was statistically indistinguishable from the reduction in heart failure hospitalization rates in patients that never had heart failure before. So this may be pushing the envelope a little bit, because the study, we should state very clearly, that was not powered for heart failure, but it suggests that the drug could not only prevent clinical deterioration in patients with overt heart failure, but could somehow prevent the development of new heart failure, which I think is a very important potential finding. Obviously, these are hypothesis generated. Mm-hmm. It's secondary outcomes. It's attractive because it kind of makes sense, right? The heart failure, the cardiovascular mortality was surprising. The heart failure hospitalization was not. In fact, many of us have been encouraging heart failure trials with this class of drug for many years. So we will know, I think, in a few years. These studies are now just getting underway. There's an empagliflozin study known as EMPEROR-HF, and here they will be looking at both HFpEF and HFrEF patients. I think there may be two studies, but they may be pooled in their analysis. And dapagliflozin is also undergoing a study known as DAPA-HF, and that is strictly a HFrEF, so a reduced classic heart failure population. I believe those studies, which are just getting underway, will have some results in perhaps 3 or 4 years. So until then, we won't know for sure, but it's very important data, I think.
But those studies, unlike the others, are being powered to be able to answer those questions.
Absolutely. These are heart failure trials being driven by heart failure experts. And interestingly, they're both recruiting both patients with and without diabetes. The heart failure community is very interested in this class because of the EMPA-REG signal. But the question is, will the benefits be seen again in the diabetic population? We hope. But will they be extended to patients without diabetes? Because there is a glucosuric effect of these medications, even in patients with normal glucose tolerance.
Or in prediabetes. It would be fascinating if perfectly normal glucose tolerance didn't benefit, prediabetes benefited, and diabetes benefited, you know, as a total hypothesis concept.